Sorry to keep people waiting. Um, I was a bit anxious not finding Dr. Amy Price here. Although Dr. Tausif and Dr. Avinash are here, uh, they are the students in our network who are going to talk about the topic today. And in brief, we are essentially talking about scholarly integration or medical integration research. We also came into this project because of a book chapter which has been hosted by Dr. Atkoli from Pondicherry. And it's very interesting as to how, if we just create a gist of it, it's nothing but a participatory framework of a learning ecosystem where the patient is put at the center. So we shall be sharing our experience of how we have been doing it over the past decade and what are the challenges we have faced. We've got two of our presenters here, Dr. Tausif, Dr. Avinash, and our presenter from Stanford, Dr. Amy Price, who was supposed to join. I'm not able to find
Dr. Rakesh, I just talked to
the
Dr.
audience right now.
There is some, she'll be joining a bit late.
She'll begin.
Because she has told us to begin. There is some time zone issue.
Dr. Tausif, would you like to start sharing about the participatory framework that we have and our entire learning ecosystem as to how much and what you have been exposed to over the last few weeks and what you have done and added to this ecosystem. And hopefully by then Dr. Amy Price will be here.
MBBS of fourth year and from Jinan University, China. And I enrolled my program under the guidance of Dr. Rakesh Mistry sir earlier this year in the month of February. So it has been a very so far for me because as William Osler said very kindly, to study the phenomena of medicine of a disease without books is to sail uncharted sea. But to study books without patient is not to
not able to communicate here.
Sir? Hello? So am I audible?
So the laptop battery is suddenly running. No, you can put it here only. In this, if you can connect the power supply.
May I continue?
You want to take it somewhere? I can go and sit there. Not necessarily. Yeah.
Yes, Tausif, please
You
continue.
can continue. I have
Yes,
co-host. You can share screen also.
Yes, sir. So I'll be continuing from. So actually, from what Sir said years ago, I not only realized the significance of reviewing lit, but also the need of patient-centered learning to master the art of medicine. With the evolving trend in medicine, IT has brought significant global integration, which in these challenging times of the current pandemic especially, has been medical, especially through online learning. So online learning not only brought the textual knowledge closer, so rising above all the geographical barriers definitely, but also helped me attain towards patient-centered learning. So as a BMJ elective student, my visit to Kamineni Institute of Medical Sciences, Nakitpalli, this in the month of February, under the guidance of Dr. Biswas, I saw key challenge cases that very finally brought the global health concern around each
The thing is in this webinar.
and brainstorm is to figure out solution to those problems. So with the help of online-based data research, sharing of inputs over various platforms and social media, we got great help in figuring out really great uncertainties around various cases. Under the BMJ elective program, some of the important activities that included was like maintaining case-based e-log with, of course, the sign consent and identifying the patients and sharing the case-related data for global inputs from healthcare professionals. And of course, we did a case-based review presentation. So it was basically we took a case of a patient who was suffering of a 62-year-old having cough. and try to figure out the uncertainties around her diagnostic, around her diagnosis, and of course the challenges faced during treatment. So on the basis of that, we created a video presentation, a case-based video presentation, and that was a part of our one of the projects that we are undertaking. So we have also been maintaining a graphical timeline of each patient, showing the various time of admission of the patient, the patient's vital signs,
Wait.
waiting, and also the kind of intervention that was required, and how so these changes over the vitals on the basis of the various intervention over a given period of time gave us a very good graphical interpretation of the timeline changes that had occurred in those patients over the period of time. So also artificial intelligence based knowledge graph is one of the projects that our team is currently working. So as I already mentioned, we are writing a chapter to application and research that on scholarly integration. Unfortunately, my stay couldn't be permanent there at Combination Institute of Medical Sciences for a longer period of time. So I was there around 4 weeks over there. But what kept me string to the program was online-based continuous discussion around each project and a collaborative team effort. Very recently, I would like to share two incidents that helped me bring significant outcomes via online-based interactive discussion. So one of those was a 15-year-old female with coccydynia that progressed to restricted mobility of the patient. That actually worried the family, and the doctor has said Oleocrine TB history of 2 years ago that was treated with antiviral therapy. So the doctor became so when she visited the physician, the doctor probably after becoming too apprehensive about going to her previous past history maybe, so without much of physical examination and clinical interpretation, he advised lumbosacral MRI and with an X-ray pelvis with coccyx, AP and laterally. So after the reports came in, there was no significant abnormality seen. So the doctor prescribed some analgesics and multivitamins to the girl. But the agony of the patient further increased over 2 days. Sooner, her brother, happening to be a medical student, used clinical wisdom of physical examination and found some erythematous swollen lesion with white spots around the coccygeal region. So apparently that turned out to be a subcutaneous abscess. So had there been a fine physical examination in the very initial stages, and so they have been restricted over diagnosis and over treatment of the patient. But thankfully, because of the sharing of the data with via various social media, inputs were received from various healthcare professionals, of course, and they prescribed antibiotic. After this, within 2 days, the abscess ruptured. There was a lot of pus with blood, and the girl was apparently starting to play football the very fourth day. So this was one of the experience, and the second experience was so. Before I go to the second experience, I would like to emphasize here. In this case, we see how the patient itself, online based or through through various social media interaction or sharing of the brought significant outcome in the patient. Whereas in the second case, which I'm about to discuss, we see not only the patient's suffering was further reduced, but also the caretakers, the patient caregivers were quite benefited. As in this patient, that was 64, fighting with COVID pneumonia, showing a CORAD 6-score NHR city, was on ventilator and was advised by the doctor for ECMO therapy, extracorporeal membranous oxygenation therapy, which was estimated to be a cost of around 1 crore rupees by one of the private hospitals in Kolkata. So the hospital where the initial treatment was occurring, they suggested they referred it to a different hospital where we have the ECMO therapy. Apparently, only I think 2 private hospitals in Calcutta offers ECMO therapy. So he was referred to one of them, and they gave an estimate of rupees 1 crore, saying that there would be a 50% chance of the patient recovery. The patient caregivers were quite apprehensive whether to go for it or not to go for it, because they didn't want the patient to be all right. So with a quick review of available evidence of the ECMO therapy, when we were approached about it by the elective students team, the family was suggested to save the resources and opt out of the treatment, as it would provide little or no benefit to the patient based on the available evidences. Sooner the patient rested in peace. After, like in few hours, I got news that the patient expired. But this actually not only further lessened the suffering of the patient, but also relieved the family with an extra cost burden, which they were already undergoing and had spent a lot of money in the when the patient was on ventilator in one of those private hospitals. So that had their if they would have not have decided to risk that time, they would have lost a lot of resources for. So remembering Osler once again, he said, medicine is a science of uncertainty and an art of probability. So such art of probability via scholarly patient can help us unwind the road of great uncertainty sometimes. Thank you.
Thank you, Tosif. And I will continue. And after that, Professor Rakesh will continue then. So, my name is Avinash Kumar Gupta. I am a medicine student. And I have been involved with BMJ Electives program and UDHC network since last 4 years. And the way we have been doing lots of online learning, especially during this pandemic, is a student first visit to a patient and take their history and detailed examination. We try to prefer on taking history in narrative format, so that we can get more detail about the impact happening in the patient's life, about social, financial, and all other issues also. And beauty of narrative history is even a layman person can take a patient history and share to the online network. So once we get the patient details, then we try to analyze.
Sir, you got muted, sir.
Sorry. So I don't know when I got muted, so I'll repeat. So a student visit to a patient and take the history, and we try to focus on taking history in narrative format. That also enables a layman to take a patient's history and share in the online network. Once we get the data, then we analyze it, and depending on the case, we also question for further information. And after that, we try to find the diagnosis and discuss around the medical cognition of that patient issue with the students. So recently there was one patient, like that was a very complex rare undiagnosed patient, so it was a good case to just dig deeper and find what different hypothesis possible, and also some other cases which were day to day common life we encounter. So we discussed through those cases, and around 200 students from a class prepared their e-log book by analyzing it and sharing their own hypothesis on what may be possible conditions, what may be possible biochemical processes affecting that patient's life, what may be the way to discover and what is causing problem in this rare undiagnosed patients since last 40 years. So this practice in online group, maybe WhatsApp, maybe Facebook, so wherever we are doing, so this helps us to stay active during this pandemic and actively involve in learning, engage in problem solving, explore about the uncertainties, explore about the patient problems and their impact in their life, and all with a group, so in a network. So the learning is exchanged together, so it's a very useful alternative to classrooms during this pandemic, and we have been doing this even when the pandemic was not there. We have been continuing this since last 3 years, even more. Yes. So I would like to show one of the case records that I have prepared. So how can I share? Okay, I cannot share my screen. Tosif, can you make me co-host, or Bedi sir? So the e-log books we prepare, they are actually on the online available always, and the patient identifiers are removed. So, and it's always they shared there with patient's consent. So we have a signed written consent, and after that a student can submit their e-log book link or a print of that to get their evaluation. So I don't think I'm able to share my screen. So
you are the host now. You can share.
thank you, sir. I'm not finding the option to share the screen. Tausif, can you share the screen? Oh, thank you, sir. Now I'm host.
The host can share, Avinash. So
Yes,
you're the
yes.
host now, you can share now.
Share screen. Desktop. Share. So this is my e-log book, my learning portfolio, classwork December Jan.blogspot.com, and I have been updating my cases and other different innovative ideas sometimes that I try to think to solve patient problems, and I would like to show some of the cases that I have built here, and occasionally I have also updated the case discussion, but mostly that is going on WhatsApp. So 70 years old man with a neck mask, and there is narrative history, some relevant clinical images, and here we can see useful discussion. So this is part of our learning process, and when we are discussing in a case based method, so it is more impactful to remember and even to understand the depth. So not only discuss the cases and solve the problems around it, but sometimes we also try to innovate what may be better done for the problems. Like we have been monitoring a fever, sleeping, obstructive sleep apnea, so sleep pattern of a patient, and we found that a simple pulse oximeter can be used to detect effect of sleep apnea during night. Not necessary to, like, it is not, I would say not necessary, it is not possible to have a sleep study on a regular basis at home setting. So even a pulse oximeter and someone ready to monitor can find if a person is having apnea. It may be good for screening. So that is one of the innovative ways possible that came out of this. Then case based blended learning ecosystem. So sometimes we discuss cases for research purpose. We try to make a case report out of it. So this is data copied from one of such discussion. Then sometimes we also tried frugal innovation, like in time of COVID. There are different frugal innovation getting famous, like if a fan is kept in front of a patient mouth, then it doesn't improve dyspnea, it doesn't improve their oxygen saturation, but helps in improving their dyspnea. Similarly, there was a stethoscope hack that we tried. So we just connected earphone in a stethoscope bulb, so microphone was inserted inside and then connected to a mobile, and this was able to record the auscultation sounds and share it over the WhatsApp network. So this way we have been trying different innovation, and we have been going deeper into different cases, and it have been helping us a lot, and I would request our professor to continue. So sir is not there. Madhav or Vivek, are you there? Dr. Madhav? Okay, so sir is not there, so maybe we'll wait for a few moments and I'll inform him.
Yep. Dr. Amy is also just joined.
Yes, Madhav, would you like to show your portfolio e-log book on the website?
Okay.
Hello.
Yeah, thank you, Avinash.
Hello.
But so sorry,
Yes,
I
sir.
was not able to
Madhav is presenting now, and
laptop
after
to
that,
join.
we
That is
need
why I
you.
cannot showcase my portfolio as well. But
Okay.
I would like to definitely share some of the experiences that I had during the PMG
Okay,
elective
sir.
course that has happened. Although I started my
Yes, sir.
journey of PMG elective
Yes,
course
sir.
3 years before,
Okay, sir.
along
Okay,
with
sir.
alongside of Dr.
Okay,
Rakesh.
sir.
It
She
started as
haven't
only
joined,
an
sir.
offline 20-day course, but it has gradually been extended so far online with numerous discussions around
Okay,
numerous
sir.
number of cases and guiding many students as well during the
Yes.
part of the
Yes, sir.
courses. It is the first time. I mean, the difference between a
Okay,
PMC
sir.
elective course and a
Thank you, sir.
traditional online medical education is mainly has been a different aspect that we get to see. The first aspect that that I got to see when I was a medical student, and I was a medical student. I never understood the term informed consent to the pay. What is informed consent and how important a role it plays during the part of the journey, because of our role, especially explaining a patient importance, and also a lot of online creating these online e-medical records that we are mentioning as blogs, which Avinash has noticed. These informed consent has played a very vital role. And whereas in traditional medical education, I often did see, I did not see any kind of informed consent that has been seen. That was the first thing that have learned during I have learned during the part of the journey. And the second thing that I have learned during this journey would be once the what do we say, the conversational standpoint that we get during the part of the journey. Let us say that whenever I was a medical student, I used to I asked my professor, and my professor would ask me to go to cardiologist, get this referral case done, then go back. Then cardiologist just refers something, and but there is no actual communication that has been happened between the two experts. But during this conversations that is being happening, it was happening in a single WhatsApp group, or single face to face, that I become a point of contact. And the care has been properly happened, and in-depth information has been seen from the entire patient. During this in-depth confirmation, a lot of times, a lot of clinical problems has been identified and further discussed to solve these clinical problems, and this improved a lot of evidence-based medicine and medicine for students. This is,
I'm on.
ਤੁਹਾਡੇ ਕੋਲ ਹੈ ਮੈਂ ਕਿਹਾ ਮੇਰੀ ਫਾਈਲ ਪਤਾ ਨਹੀਂ ਕਿੱਥੇ ਗਈ ਮੈਂ ਇਹ ਕੋਈ ਹੋਰ ਮੀਟਿੰਗ ਅਟੈਂਡ ਕਰ ਰਿਹਾ
Avinash, Dr.
yeah.
Amy is here. She has joined in, so maybe.
ਓਕੇ
Yes.
Hello, me ma'am. How are you?
Hi.
ਅੱਜ ਕਿੰਨੀ ਹੈ
Yeah, would you like to take over? I just completed with my experience. This is Madhava this side.
ਕੱਲ ਦੀ ਹੈ ਕੱਲ ਵੀ ਇਹੀ ਟੌਪਿਕ
Okay.
Amy, I have made you the host. You can share screen.
Okay. Don't actually. I won't share the screen. What I'll do is I'll share briefly a little bit about my
ਆ ਬੋਲ ਰਹੀ ਹੈ
background and about case study and what I've done with the group. Would that be okay?
Yes. ਆ ਇੱਕ ਵਾਰ ਬੰਦਾ ਕੀ ਕਰੀ ਜਾਂਦਾ
Okay. Sorry, everyone. Glad to be here with you today. My name is Dr. Amy Price, and I'm a senior research scientist with Stanford University, and I also my doctorate is with the University of Oxford. I actually met this group when I was doing one of my graduate degrees, and I want to share how much medical education working synchronously across platforms with patients, with medical students, with consultants. I've seen this change lives, and I have seen it change lives here, even across cultures, and where people are given the option in a real way, a real life way, where in a normal clinical encounter, they wouldn't have that kind of intimate relationship, and they would also not have the opportunity to record it so closely and to learn from it. And one of the examples I remember is a discussion that was carried on about the surgery of a young woman, and she had a tumor across her face. You remember the group did surgery on her with her full consent, and it was so unusual that people were looking up case studies, they were looking up evidence, and as they went along, they had no choice but to move forward, because otherwise the young woman would have lost her sight. And I remember the beauty of seeing that the woman regain her sight. Afterwards, there were some complications, which is not unusual in that kind of a surgery. But it's something that I think that medical students and teachers and surgeons seldom have the opportunity to learn about together. And learning about things together, you can learn about a case, you can learn about the culture, and you can learn for your next patients, because you're developing also that kind of pattern recognition, and you're taking advantage of the pattern recognition that is developing in other people at the same time. So it's a group activity. And then the other wonderful thing is when I would witness and be a part of writing up the case reports and what happened to the patients, and you could see what areas were quickly and easily forgotten, and it took the group to bring it all together, and what areas no one forgot, that everyone remembered together and was clear on. And it also showed how many things were beneficial that could be carried on, just about practicing medicine and carrying on to the next patients. And the other thing that was important was that everyone had a voice, from the social worker to the patient to the providers, to the medical doctors, to the students. And I think that it also helped to change the culture of a country. For example, I learned that when there was difficulty with gaining equipment or blood or anything that was needed for the patients, that the professors and the students, they would join in, and there were funding campaigns to help patients get equipment and to get medicine. And it also made it clear what kind of services were difficult to get, and how rare some of these services are in rural, for example, patients could get very good care. But some of these patients, unlike in North America, where they've visited professionals frequently, some of these patients, they would be quite old before they saw a physician, even for the first time. And I can only imagine what it would be like for the patient and for the family to have to make that introduction to a doctor, it not being a normal part of life. And then we also learned how difficult it was for some things like prescriptions. For example, if people in the family, the only person that spoke the language that the prescription was in was maybe a child and did not understand the context of the prescription or the directions, and how misunderstandings could happen. And I think that when people are studying and working on this as a part of medical education, then you see medicine really the way that it really is, the way that it really is for patients at home after they've had time at the hospital or after they've seen the doctor, and they look at the medications and they think to themselves, well, I can't really read it, so what do I do with this? I do I take it by mouth? Do I put it somewhere else in my body? How often do I take it? And that some of the things that would seem simple to us are not so simple, and how important it is to have good follow up, and to have good instruction and training that are in the language that the person who is going to be taking the intervention or the medications can understand. And I also think that this training is really a great almost insurance policy against patients being taken away by junk science, where they're asked to pay a lot of extra money, but they are not getting benefit for that money because the medications they're given are bogus, or they're not evidence-based, or they're not good for their particular condition. But when the patients and the doctors and the social workers, when everyone's learning together, that's far less likely to happen, because there's a relationship there where the patient can go to someone who knows about the practice of medicine and can actually ask, instead of being taken advantage of and have their money taken away for something that's going the other thing that I found was really helpful was the blending of the traditional medicine with the practice of the practice of medicine as as we know it, because many times the patients all their lifetime they practiced traditional medicine, and it had been an important part of their life in keeping them healthy and in keeping them confident. And I love to see those areas of medicine and community practice, blending together. And so those are just some of the things I learned a lot also. I learned a lot writing together with Professor Biswa and with the students and with other team members. And it's an amazing thing that for many of us, the only way that we've met and worked together over many years is online, over the internet. Yet for many of you, I know that I feel almost like that I have met you in person. And when I did get the opportunity to come to India, and we were all at a conference, how wonderful it was to meet together. And I'd love to just pause for a moment and ask if you would like to leave questions or comments or observations in the chat. I know we have similar programs at Stanford and at Oxford University, but they're not quite the same. So sometimes what we will do is we will have patients come in to the medical school, and they will teach a group of medical students about their condition, and then the medical students will break into groups and they will solve a specific problem for this patient. So the patient will say, these are the problems I'm having, and how can you help me solve the problem? And so the patient and the medical students teach each other, and they're also guided by the instructor. And in many cases, when at Stanford and also at Oxford, when we write up the reports, we ask the patients and their families to write along with us, and we include that also in our publication. We ask them also for ideas for future research, because sometimes they will think of ideas that are so practical and unique, and are relevant to them, and they may be things that we in the field have not even considered. So they can be a great source of inspiration. I have seen times when a medical student or a professor or a doctor has been just discouraged and exhausted just by the weight of the amount of patients they have to see, and maybe the lack of resources, and sometimes just a patient that's grateful and cheerful and encouraging can make the difference between feeling depressed and being lifted up and inspired to continue the practice of medicine. Can people hear me?
Yes, thank you, Dr. Amy. So
Okay.
this was a futuristic, especially, I mean, for India, it is a bit, we are moving in this direction. So can you just explain a roadmap by which this can be implemented in our ecosystem?
Yes, I think that the thing is just if you can start early, and the medical curriculum is very intense in all countries. It takes a lot to practice to be a doctor. So there's almost no way to substitute what is already being taught for the actual working with patients. So there has to be ways to implement that into the existing curriculum and into the existing work stream. So one of the ways that is very useful is if the medical students and their professor decide to take a case, like as Dr. Biswa, Professor Biswa also has done, and which we also do at Oxford and Stanford, is we will take actual cases and we'll use those cases for training and ask the patients to work along with us. So when there's a part of the medical curriculum is being taught, the testimony or the voice, the actual appearance of the patient will be brought into that training, and it will be recorded also for others. So I'm not sure how helpful that is. So maybe could you ask more questions?
Okay, anyone would like to ask questions? You can unmute yourself and ask. Yes, Tausif.
Thank you, Dr. Emmy, for your valuable inputs. So I'm Tausif Javed. So I have a question. As in, you said that this kind of curriculum earlier in the medical curriculum. So, or like yeah, it's a 5 years course. Like it's 5 years course. So there are pre-medical subjects in the very first year, and then other subjects that's coming. So I think some basic knowledge and understanding of the medicine is required in order to assess the course of a disease or to analyze what's the problem around the patient. You said early, so what I have been seeing that the case-based learning actually is in the around the final years. So how early do you sit? So what topics that should be covered before we actually can approach towards a patient? Center.
That's a great question. So what we do,
This, as far as I know, this has to be directly linked with the route.
Please mute yourself All of you, please mute yourself if you are not asking a question.
Hi. Okay. So the question was, how early, and given that a certain degree of knowledge of the disease and the treating of the patient might be necessary, what we do is we pair very early medical students and even pre-medical students, and we pair them with more experienced students, and we will give them a patient to work with together. So for example, the early medical student, they wouldn't maybe not necessarily have anything to do with the treating part except just to observe the older medical student. But what they would do is they would have a part in comforting the patient, making them comfortable, and acting as a help towards the older student that has the experience. And the older student that has the experience becomes like a teacher or a mentor to the younger student. The other thing that we've done is we would give a group of very young medical students a patient to solve a specific problem that the patient wants solved, that maybe has not so much to do with their health, but maybe has something to do about making their treatment more comfortable, about communicating with their family, and their urge to work with the patient and to solve that problem, and then to bring the solution to the older or more experienced, more trained medical students who would work with their professors and their teachers to bring that into medicine. So we have actually done this as early as even before med school, and we have worked with our medical students, and we have brought experienced patients in, and for example asked the experienced patients would share ahead what it's like to have the disease that they have, or the condition, what it's like for them, and how many what they have to do in the course of treatment, what it's like for their families. And then we would ask the students and the patient to work together to find a solution to some aspect of that patient's problem. For example, somebody might have a memory problem, and it as the basis of a neurodegenerative condition. So, and they would say, what I really dislike is when my family asks me all the time, do you remember this? And so then what we would do is we would share with the students, and the patients would share, what would you like to do instead? How could your families and your teachers communicate with you? And the patients will say things like, well, they could show me a picture, or they could give me a hint in case I can't remember. They could ask me about the question in another way. They could maybe it's the language that they're using, or maybe they could act it out for me, because it's very early. We are finding that it's very early clinical exposure. It also helps our medical students to develop like the empathy and the understanding of what it's like to communicate from the patient perspective. And we find that these students that are brought up early with this early exposure, they gain respect for their more experienced teachers, both the experienced students and also the clinical instructors, and they gain respect for the patients, so that when it comes time for them to be working hard in the practice of medicine. They're not the same kind of students that are constantly complaining about how hard it is and how this information is unnecessary, because they have seen working firsthand with the patients that all the information that they've taught will become necessary within the scope of practice. So it makes the medical students more diligent. It gives them empathy, and it also gives them the experience of not necessarily being just competitive and intelligent, but also working together as a team, because everything within medicine almost has to be teamwork. And so it's more than just practicing medicine, but it's also working together in medicine for the patient's greater good. That actually extends to when you're writing it down, not only as a case report. How could you write that down so that if a patient or a grandmother or someone's child was seeing that report, that they would be able to understand it? So then students learn that they write for an academic audience, and they also communicate to be understood by the people that are around. And many of us here know more languages, maybe 3 to 4 languages or dialects, including English. And after a while, when we become practiced in those languages, we can think in each one of those languages and we can translate effortlessly. But what we find is with only normal medical exposure, the kind of medical exposure that we are that is common, when the students or the young medical doctor has to actually communicate with the patients and with the family and with people outside of medicine, they're lost because their language has become full of shorthand or jargon that we use to communicate, and the patients look lost. And then what happens is the young doctor will try to simplify, but then they simplify so much that the information is lost. So there's a real balance between learning how to communicate medical education and medical interventions simply and well, putting aside the jargon, but getting the message across. And when we do this, it also helps us to work with people who are outside of our culture or outside of our area, because we learn to listen. We learn to listen to every aspect of the patient, to watch them, to pick up cues from their faces, to pick up cues from the way that they move, and to pick up cues from their language and from the people that are working with them. And I'm seeing some questions in the chat, some excellent questions. A common question I hear from medical students is how to find a mentor who will direct me towards early clinical exposure, because it's not part of the curriculum. And this is really, really such an excellent question. And also, many of you can join us on, they'll put in the links to the chat on our Facebook page, and in the different places. We welcome you to join, and we welcome you to join early. And as you join with us, you can watch initially and kind of make yourself comfortable. There's no question that you could ask that would be too beginning, because there will be medical students, there'll be professors that will be happy to help you. For example, even in our group, there'll be areas of medicine where I don't know anything about them, and I'll just watch the case and be so interested to watch this case evolve and to see what's happened. And I myself have picked up information that I have learned on the Facebook page, and through the case reports, and I have seen that same kind of scenario in another patient, and other medical people are struggling, and I'll say, well, I saw this, maybe this is an area where this intervention might help. Because the other thing that we do is we also look at the evidence around the question. So we'll say, this patient is presenting in this particular way. These are the symptoms. What do you think could be the problems? What do you think could be the evidence around this? And as far as getting a mentor, I get asked this question so much, and it's an important question, but it's also can be the very easiest way to get a mentor is to become a mentor. So how can you mentor people that are around you? Because as you start to mentor others and find knowledge for others, then what happens is that becomes noticed, and people around you will take an interest, and they will also want to reach out and to mentor you, because they see that are valuable to the medical ecosystem, and you'll find that you will end up with more mentors than any one person could ever need. And there's some things that are important about mentors. Sometimes we expect a mentor to be everything, and people are not capable of that. They're busy, they're not perfect, and let you down to expect too much of them. So the one thing is to remember is to see the mentor as a mentor for one situation, and then you'll start to develop a group of people that you can go to when you have questions, and you will also be sharing answers to other people, and then there will be evolve a group of people that you can work from, that will be overall mentors to your life. They will open up doors. They will help you to become a published author. They will help you to get into different schools. They'll recommend you. They'll coach you. That is almost always a two-way street. And also, mentors are individual. So the same mentor that might be an excellent mentor for me, they might not work as well for you. So a mentor and a mentee, they develop a relationship together, and that relationship can be almost as close friends or brother and sisters or partners. And so it's important to cultivate that relationship. So if someone is mentoring you, the very most important thing about that mentorship is not only what that mentor is doing for you, but also how can you help your mentor to succeed? How can you reduce their load? How can you make them happier? How can you serve them and respect them in some way and enhance their standing in the medical community? Because as you also do that for others, others also along your path will do that for you. Okay, so more than anything, I'm also seeing from another post, ESC will help students to know what to expect of this profession in the future, to empathize with patients and their families, and hone their communication skills as they mature. Previously, these aspects were almost completely ignored. And that is so true, because sometimes the premium is on packing all that knowledge inside of our limited mind space, and we are almost exploding with the amount of things that we might need to remember, and we forget about the human part of us, and that makes us poor doctors. So even doctors, as busy as doctors are, as busy as professors are, everyone needs to set boundaries and to set limits so that they have some personal time, so that they can actually fully pay attention Because if you're fully immersed into just valuing the things that you are pushing into your brain, and if you let your human feelings and your empathy be blocked at the expense of that, you will only become a technician. You will never become a doctor. And it's also important to know that some of the things that we see in medicine, they're horrible things. They're things that we wish that we could unsee, but that will never happen. And it's tempting to push in knowledge, to push away the things that we see instead of dealing with them, instead of facing them together. So I would say that as a doctor, as a medical student, it's okay. It's okay to cry. I started out as a patient with a brain injury. The neuropsychologist that and the neurologist that saw my brain scan at the beginning, when they saw tears roll down their eyes, and you would think, did that make you nervous as a patient? Did that frighten you? And I would have to say no. I actually felt that at least they cared and they understood. And then we looked at that situation, and together, they with their expertise and me with my willingness to learn from them and to apply what was shared, and to add to that my own imagination and way of doing things, we worked together towards a solution, and we built solutions that were considered beyond what was medically possible at that stage. And you will find that if you work in mentorship and to develop that empathy is not something that just comes. Empathy is something that can be learned, and empathy should be learned. Sometimes people convince empathy with sympathy or compassion, but it's not the same. Empathy will treat all patients with curiosity, with respect, and with compassion. Empathy doesn't play favorites. Empathy finds it as easy to be compassionate to a rude, smelly, unattractive patient, as it does to a patient that is beautiful and has a great hope of recovery and who is pleasant and kind. And the practice of medicine requires us to be empathetic to all patients, and that's a part of our Hippocratic oath, which is a part of doing no harm. And that means doing no harm to any part of the patient. And also, when we have empathy, when there's news that is not good and we're the ones that have to break it, if there's an empathy and a bond that we can quickly build with the patient, because that's become a part of our medical lives. If we can do that quickly, then when we give news, that news is softened by the empathy and the hope and the support that that patient feels from us. And that can be developed even in very early medical students. They can practice how can you share bad news? How can you bring hope in a time where there isn't much hope? How could you comfort a family and yet be truthful? And you can deal with together how much emotion is it okay to share? How much distance should I keep from my patient to remain professional? These are all questions that are learned through practicing together. So I think are there any other questions, or should we maybe go on to the next speaker?
There are no more questions. Tausif, can you
Yes, sir. Thank you so much, Dr. Amy, and all the other speakers here, and all the participants for joining us today. So it was very enriching experience, and we got to learn some really important point about early, integration of the students in the case-based, case-centered or patient-centered learning, which is very important right now. So also, I would just like to mention one part that during my elective stay, I learned something very important. That was I came across certain diseases that were termed as orphan diseases. So after discussion with Dr. Biswas, he told me that there are many diseases that are actually not orphan but are less reported. So with this early intervention of the students, when we actually start reporting diseases and we actually more data is available, then such data will be very useful in treating up diseases that have not been reported actually. So those diseases that were actually termed as orphan, many of them wouldn't be orphan anymore. So this does not actually only holds true for only orphan diseases, but for many diseases that we can actually report, and I can actually bring about the impacts or the outcomes that were quite positively brought in those patients, and these can serve as really good interventions for other patients that can be experiencing for similar problems. So I think, as said by Dr. Ami, and that early intervention or the interaction of the students in the based or patient-centered learning would be a really impactful effort in bringing out great changes around the patients. So, and this can
Um,
you develop quite finely over the online or the online based learning through scholarly integration in medical education and research. So
I
yes.
was just trying one thing that, sorry, that creating a network of medical students in which regularly such case reports placed and maybe they can be discussed either in the same college or multiple colleges uh, would be one way.
yes,
And one really important thing
Hi
that
bro.
I've
Hi
learned through
bro.
this is, for
हाँ
instance,
बोलो कुछ अर्जेंट है?
if you have a group of patients where maybe
कब
there's
क्लास है?
not so much known about the disease, or even
तुम लोग
if
जा रहे
there
हो?
is, but there's questions
अरे
about
घंटा तक कोई
treatment.
नहीं जा रहा तो क्यों जाएंगे?
If you
सुबह तक
record many cases,
नहीं. जब
as
सुबह को वो हो
almost
गया बंक तो चलेगा
sees
रूम पे अपना.
like case reports,
अगर बंक
and
ना हो
you
रहा हो
see
तो
that
बता देना, ठीक है?
the patterns that evolve, some of these patterns
कहाँ जाने का
are
है
not well
पोस्टिंग?
reported, but they really help us in
कौन गया था?
recognizing that disease or challenge in a new patient when we see
अच्छा
them.
वो लोग गए थे?
And one really
तो
important
हुआ है पोस्टिंग?
area is we did this with a
अटेंडेंस
group
मिला
early
है?
on with a group of patients that had
हम सो रहे
Parkinson's
हैं, कल
disease.
देखेंगे क्या करना है.
And I
अब
remember
अटेंडेंस तो
very
शॉर्ट हो ही
early
रहा है.
on
हाँ?
going into a hospital with
क्या?
my husband, and there was a patient in
क्लास
this
नहीं आओगे?
hospital, and the patient was stuck
छोड़ो
in
जो
the
होगा देखा
wrong
जाएगा.
ward.
जब जाना तो
So
बता
it was
देना, मैं
an
भी आ जाऊँगा, ठीक
orthopedic
है?
ward, and the
ठीक, तुम
patient
हॉस्टल में
came
हो तो तुम्हें
in,
थोड़ा पता
and
रहेगा.
the patient
यहाँ पता नहीं चल
collapsed.
रहा है कुछ. ठीक है,
The
थैंक यू
patient
भाई.
had a little bit of a strange gait, and I remember the ward attendants, the nurses, and the residents were saying, "Well, this patient is badly behaved. They have dementia." And I said, "No." I said, "There's a neurodegenerative component here. Um, let's look at the gait." And because of what I learned from the case reports, I was actually able to guide them, and we learned later that although this person could not communicate well, they had an advanced disease of Parkinson's, and it had gone completely unrecognized. And Parkinson's is actually a pretty common disease, but when we see things in an unusual environment, sometimes we don't recognize them. So it's as we develop case reports are an important way for medical students and for those that are advanced in medicine to learn together. So my counsel, advice, encouragement would be to bring case reports into the very earliest part of the learning and to keep up that kind of learning with the case reports all the way through our training. Because the other thing is it leads to knowledge about what drugs can be tolerated and are not tolerated, because what you see in a clinical trial is, for example, not necessarily how these patients are experiencing that medication in their own homes. But the other thing is sometimes it can lead case studies can also lead to new interventions, because when new patterns are recognized, that can also lead to an open doorway to new innovations and new interventions, and it can also catalog maybe unmet needs. Where, for example, in the early years, when patients with mental problems would be given psychotropic medications, the medications would make them ill. It would make them fat or obese. It would make them unable to have direct but and so the patients would just, even though it helped their symptoms, they would stop taking the disease because they were unable to communicate normally in the world, and they were losing their appearance, and they would say things like, not only am I crazy, now I am, I'm obese. I can't move around, and it's just not worth it for me. So, because of that feedback, newer medications were developed that don't have those same side effects, but without series, hundreds and hundreds of case reports over time. We would never have that ability to gain those insights and to do research about the symptoms that patients experience. And this, if we develop this early in the medical education, we develop doctors that are curious, that are insightful, and that are not afraid of looking for innovative solutions, and who also examine those solutions carefully and look how much evidence can be attached to the solution, and look at the risks and look at the benefits. So I'd also, if you check online with some of the case reports and things that we've been doing, you'll see that pattern develop. And we also found, in terms of sometimes maybe the books say a certain doctor or type of professional should be delivering an intervention. But in real life, that's not the case. Sometimes it's someone much less qualified that's actually doing that work. And no matter what you say, you can have a moral idea about what you feel is right, but that practice is going to continue. So what can be done is medical students and their professors can teach those that are less trained to learn that specific procedure, and you can reduce harm in the local communities, because you can make a worker skilled in that specific area, so that they are able to carry out the intervention with close to the same skill as a physician, but they would be also, of course, monitored by a physician in most cases. But in many cases, there is no physician, and in those cases, we need to ask ourselves: is it better that we train people that are actually doing the work, or let the patient suffer? So this is also another way where more advanced medical students can be used, is they can be used to train others in the community, and to motivate them also to get more training. So I'd also like to just bring that up about the platform. If there's mentors available, if there's help available to train those that are less qualified. It's not like doctors that are trained are ever going to be out of work. We're all absolutely overworked, and if more people could be trained to do the tasks that doctors don't have the same amount of time for, and if they can be trained within their communities to do those tasks with excellence and under supervision, then we can also create healthier communities. So I wanted to share that as well. Also, doctors that learn to work with patients, they become more skillful in sharing the decision-making process, so that the patient is recognized, as an expert in their condition, but the doctor is recognized as the expert in medical care. So then there's a collaboration or cooperation between the patient and the doctor, listening to each other and coming about with the best solution. And I see someone also has their hand raised. Please share.
I don't think there are any more questions.
Okay. Okay, well, thank you very much, and sorry for the lateness. There was a confusion about the call, and I actually thought it was like for late the next day, and so I didn't even have a link at this point. So thank you for people that got me organized and started, and just the communication's a little bit more formal, but sometimes we have to work with what we have and where we are, and I want you to know that it was a great honor to be sharing with you, and that I respect and I cheer you onwards, and I want you to know that in the area of the pandemic, all over the world, we're thinking of you, and we're trying to all think of ways that we could help what you're going through. I lost my own husband to COVID, so I know the pain of that, and we are also working with 5 World Health Organization hospitals that are running trials to make interventions better for patients. So we see this close up.
Alert from your disk is almost full.
I just want to give you the message of hope that all over the world that we're crying with you, and we're also cheering for you and praying for you, and that one way or the other, as a medical community, we're joined side by side, and even though you feel alone and exhausted, we appreciate you, and what you're doing is making a difference, and one day we will all get through this together. So thank you so much for having me join you, and I appreciate you. Thank you so much. Bye.
Thank you, ma'am.
Thank you, Doctor.
So,
Yes, Doctor.